Good morning, everybody. Thank you so much for joining us today. I know it's the height of vacation season, so I'm really grateful for the people who've made an opportunity to be here. And I apologize in advance. This week, our office suffered the death of a woman who had worked for us for 38 years, really an integral part of our office. So I'm going to be starting the meeting and then leaving to go to that service, but I'm going to leave you in Alice Casey's capable hands. We begin today, as we always do, thinking about where we are in the way that we measure, which is with our numbers. And obviously, keeping in mind that any death, particularly as it impacts a circle of people, is too many. We do continue to see that in last year, in the period between January and August 7th, we experienced 119 non-suicide opioid overdose deaths. For the same time period this year, that number stands at 86. It's the first time we've seen it well below 100 in a very, very long time. It reflects a 28% decline in that number. And that, again, as I say, always is really due to the work of many of the people on this call, as well as some others who couldn't be here with us. But we have really made this a community effort here in Middlesex, and we're seeing that result. A reminder, of course, that we continue to need to work is that the rise has continued this month in terms of those opioid-related deaths that we are calling a death by suicide. And remember, that is a pretty high standard before we do that. But last year we saw 9, and this year we're at 13. So that's a pretty significant increase. Just reminds us of what we need to be thinking about. It also, as we turn towards these last days of summer, and today is National Back to School Prep Day. And we have done a lot of work over the summer around safety and prevention, keeping in mind that summer is a very vulnerable time for our young people around alcohol and drugs. And so we've done a lot of work in the communities on education. We've been working on education and safety in general. The city of Framingham has begun giving out Narcan kits and training on Tuesdays every week from 3 to 6. And our second speaker today will tell us a little bit more about that. We have been continuing to provide both Narcan as well as the fentanyl and xylazine strips. And one thing I'm really just excited about, a little bit off this topic, but a piece of our prevention, you may have seen, but yesterday we launched our initial swim safety for kids either on the autism spectrum or with sensory or some other needs. And it is what I think is part of the most important part of our piece of what we do, and that is taking tragedy and making it to something good. We between in the last year and a half, suffered the death of 3 kids on the spectrum by drowning. And one of the things we learned as a result of that was that kids with those needs are 160% more likely to suffer a drowning. So in what was really a long-term effort, we entered a partnership with a wonderful organization in New Hampshire, Swim Angelfish, and with the Mass State Police dive team. And yesterday we had 40 kids in the pool with their caretakers. So we got a lot of great media coverage, which is what we want, because we want that conversation to be going on. We all know somebody in our families, in our communities, who could benefit from that information and those resources. So that's an important piece of our prevention. We've also been working on and thinking about some of the newer drugs that we are seeing, one of them being the nitazines. Those are synthetic opioids that have a effect that is similar to fentanyl. It's very hard to detect that drug without specific equipment. And our first speaker today is going to talk a little bit about that. And the emergence of those drugs is worrisome because it makes it harder to think about what we're doing for prevention. And also, what about patients who are transitioning to things like buprenorphine and methadone? So there's little proof that nitazines will ever replace fentanyl, but it's good to just be aware of the emergence of those things. So it's now my pleasure to turn to our first speaker today, and that is Director Sarah Mackin. Director Mackin leads the division of the Harm Reduction Services at AHOPE, which stands for Access, Harm Reduction, Overdose Prevention, and Education, the needle exchange at the Boston Health Commission. Director Mackin began that work in harm reduction and drug user health in 2010, so a lot of time in this field. She oversees the largest needle exchange and harm reduction program in New England. It provides comprehensive drug user health services to over 8,000 people a year. And I'm really happy to have her here to talk about that work, talk about the experience she's had in public health, substance use disorder, harm reduction, and homelessness, and the HIV AIDS population. So Director Mackin, thank you so much for being here this morning.
Thank you very much for having me. If it's all right, I'm going to share my screen. I have a very kind of hastily put together PowerPoint, only because I think it's helpful to share some of the visuals of the graphs of what we're seeing. So bear with me. I am a millennial, but I'm terrible at technology. So I'm not going to take a ton of time because I know that, we have several other things to talk about today. But thank you for that prolific introduction. I don't even remember sending a bio, so I don't know where you found that, but which is slightly terrifying, but also awesome. Just a little bit about AHOPE. As was already stated, we reach a lot of people every year. We're situated right in the heart of the Mass and Cass area, where the intersection of, the area's only safety net hospital is. We have healthcare for the homeless next door. Several large area shelters and many other social service programs are concentrated in this area, specifically to provide services to folks who are homeless and chronically, I would say in chaotic, sort of like their chaotic phase of drug use. So we have a lot of activity down here. And we try to do as much as humanly possible for the folks that come through our front door. So we're not just a needle exchange program. We really are a drug user health program, which includes access to buprenorphine, medical care, wound care, HIV testing, linkage to care. We were the first program in Massachusetts to start Narcan or naloxone distribution to potential bystanders, which is something that we're really proud of. Our drug checking program started in 2019. We were just by a hair, the second in the country to start doing this, right behind Chicago, who we work very closely with, to begin offering point of care drug checking. So in the moment, someone can bring in a very small sample, generally thought of as residue, that we could use either at the time we were using a high pressure mass spectrometer, which turned out not to be great, but then we transitioned over to a Fourier transform infrared spectrometer, an FTIR. These are machines that were not built for us and not built for this purpose. Generally were built for a lab setting, but just like we did with naloxone harm reduction, liberated this and started to use it on the front line to give people real-time information about what is in a substance that they're about to consume. The FTIR, it's not a standalone process. So I'm not going to go through all of the technology because that's probably boring. And also I did fail chemistry in high school. I'm not going to lie to you, but I do know quite enough about the technology and about how to use the technology that I'm a very competent technician. But in general, people will come in, they'll bring a very small sample. And when I say small sample, I mean half the size of a grain of rice, right? So like something that wouldn't even be biologically active for most people who would take it and who are habitual users wouldn't even feel it. A minuscule amount of the product that they're trying to test. We will put it on the FTIR. It will run that scan, create a composite based on the way that the infrared light is absorbed at different frequencies, and then compare that against vast libraries of spectra, and then spit out a result that then the technician can spend some time to analyze. Again, just kind of like a very quick overview of that. We also use immunoassay test strips. So we are using fentanyl test strips like everyone else, xylazine test strips, which I'm happy to talk a little bit more about. Those are a little bit more complicated than fentanyl test strips. We are using nitazine test strips as of recently, but they have not been thoroughly lab validated. And so we are using them with a heavy dose of skepticism and always in combination with confirmatory testing at a lab. So the Center for Forensic Sciences and Research Education, CFSRE, or Drug State are the two confirmatory labs that we send all of our samples to. It is really important to understand that we participate in a much larger, we are not a research study, but we lend our data to the MADS program, which is the Massachusetts Drug Supply Data Stream out of Brandeis. Their team has worked with Lynn, New Bedford, they're working in Rhode Island, Connecticut, with all of these other point of care drug checking programs to create sort of a really comprehensive overview of the drug landscape in this region. And they have a really great website called Street Check that I have the link here. I can send it to Alice after this if people would like to have access to this. But you can actually manipulate some of the data yourself and look regionally what's happening, like what active cuts or what active drugs are in certain sort of classes of drugs that folks are using. Just going to jump right into the data. Our program is one of the busier sites, although I would love to see this number rise, and it has risen over the last 9 months or so. But last year, this is 2023 data, which frankly, a lot changes in a year. And so I'm going to talk a little bit about what we've been seeing in the last 8 months in 2024. But in general, most of the samples that people bring in are street opioids. So things that are sold as dope, sold as fentanyl. Most people know that what they're going to get when they go out to buy dope or heroin is going to have fentanyl or be just fentanyl with some other innocuous cuts. There are other things that we test, though. So people will often bring in things like Adderall, or they're bringing cocaine, or they're bringing methamphetamine. Those are a little bit smaller slices of the pie in terms of what we test. But we are doing active outreach to folks that use those substances, sort of primarily because we have heard anecdotally that people have overdosed from fentanyl-laced cocaine or fentanyl-laced meth. And while we have not seen that and the data doesn't quite support that yet, we believe our people. And so we would like to make sure that we're connecting more with folks who are using exclusively, almost exclusively stimulants to know what is going on with that supply. Benzodiazepines is also another common thing that people bring in. So this is just a quick snapshot of what types of drugs we're testing. And if people have questions, you're welcome to jump in at any point. I do have ADHD. I might get off track, so I might need someone to bring me back to present, but I'm happy to answer questions as we go. So this is an example of sort of the breakdown of the things that we have found in the benzos that we tested in 2023. The purple is active compounds, so things that are psychologically or bioactively are what is the word? Psychoactively active, I guess. So like when you take it, you'll feel it, it will give you an altered state. And people will cut these psychoactive substances, these active cuts, what we call them, into drugs for various reasons. But mostly we're seeing things like microcrystalline cellulose, lactose, things like calcium stearate, dicalcium phosphate. All of these are just fillers, right, that we're seeing. And the vast majority of the pills that we test are what are going to be pressed pills, because in general, we're not seeing the pharmaceutical developed benzodiazepines that you would expect to see, which is like clonazepam or alprazolam. Instead, we're seeing bromazolam, clonazepam, flualprazolam, and these sort of very significantly different synthetic benzodiazepines, which can be much more potent. They have a much longer half-life, which can lead to overdose risk because as for some of us on the call that don't know what half-life is essentially like how long it takes for your body to eliminate half of the substance. So you may not be feeling the effects of the substance if you took a benzo on a Monday, especially one of these sort of synthetic benzos on a Monday, and on Wednesday, if you add other drugs, you're actually essentially mixing drugs and increasing your overdose risk. So there's a lot that we don't know about these synthetic benzos because they've never been tested in humans before, but there is a lot of anecdotal evidence and report backs from our people that it does have pretty severe withdrawals, and the sort of arc of tolerance skyrockets really once people start taking these synthetic benzos. Substances found in opioid samples. So like, as you can see, this is much more variety in what we're finding in our fentanyl samples. Again, the purple is the active cuts, and I can talk a little bit about some of the active cuts. The green, yellow, green, whatever, is that like the brat color now? I still don't know what that is. If someone could explain that to me on this call, that would be great. Because my kids keep saying it, and I don't know what that means, but I think that's the brat color. So a lot of these cuts here are innocuous, right? Or they're inositol or lactose, just things that you can get over the counter, or you can order mannitol on, sort of Amazon. These are just like supplements. Some of the green, like for example, like 6-acetylmorphine, 6-acetylcodeine, even acetylfentanyl, which is considered a synthetic fentanyl analog. All of these things are really byproducts of the synthesis process, or they could be precursors, right? So things that people use to make fentanyl hydrochloride. The vast majority of fentanyl that we're seeing in Boston is just fentanyl hydrochloride. So people panic a lot about carfentanil and all remifentanil, all these crazy kinds of analogs. And as of yet, we have not really seen that in our drug supply. It's primarily fentanyl hydrochloride. But more frequently, we're seeing things like parafluorofentanyl, which is slightly more potent than fentanyl, which is often mixed in with fentanyl samples along with other innocuous cuts. Xylazine is about 25 to 30% of all of our samples. So we are seeing a lot of xylazine, which I can talk a little bit about later. We did not find nitazines in 2023, but in the last year, we have increasingly found nitazines at a slightly alarmingly rate, which I can talk about in a second. But is there any question on any of the things that we're finding in our fentanyl samples? Because it's a lot of information right here. Or like some of the cuts.
Sorry, I have kind of a related question. It's not so.
Sure.
The drug checking, like, how long does that take?
It's quick usually. And it depends. It depends sample to sample. It depends on the technician. It depends on a lot of things. I would say like a good solid drug checking session is about 7 minutes, maybe 10. And it's always followed with very intensive one-on-one conversations with folks about how they're going to stay safe. So, I did a drug check this morning and someone came in and their opioid sample contains xylazine. So I had a conversation with them about xylazine, asked them about, do they have any skin issues or any ulcerations, soft tissue issues, and also, had a real conversation one-on-one about how they're going to stay safe using this drug. Some of those conversations can lead to people throwing out their sample. That has happened. It doesn't happen often for people that have to work really hard in order to procure drugs to stay well, right? So our people are not out partying. They're just trying to stay not sick every day. So most people are not going to throw away their drugs, but they might have another plan in place, such as changing the route of administration. So most of the folks that come into AHOPE are injection drug users. It may be in that conversation that we talk about, like, would you think about smoking it? Would you think about sniffing it? Would you think about other routes of administration? What is your plan? Who's going to be around you? Do you have Narcan? Do the people you're going to be around have Narcan with you? Are you going to be using with someone? Are you going to stagger your use so that if both of you go out, you don't go out, meaning overdose at the same time? So these are sort of like, it can vary person to person, but it can be very quick or it can be a 25-minute conversation. But generally the analysis along with the immunoassay test strips takes about 7 to 10 minutes. Now the FTI has limits of detection, right? So there's about a 4% limit of detection. So anything below 4% in whatever composition of a piece of a sample. Now just understand that, these are not pharmaceutically mixed samples. So, one part of the bag of drugs may not look exactly the same as another part of a bag of drugs. So all I can give them in that moment is the information that this particular snapshot of a sample that I have. There are things that we can't detect well in really small amounts. Benzodiazepines, for example, are a drug that can be present in fentanyl, typically not in Boston, but in places like Toronto, it's in like 30% of the drugs, but they're so potent in such small amounts that they aren't always able to be caught on the FTIR. So that's why we always do a benzo test strip to make sure that there's no benzos in there. So we send the sample off whenever someone is willing, which it really is, again, like a minuscule amount of product that we're talking about. We package it up according to the MADS protocol, send it to CFSRE or drugs data. That process takes a long time, and unfortunately. So it takes about a month for the lab to get back, sometimes a little bit longer, depending. And it has multiple sort of uses. Confirmatory testing is absolutely key in these point of care programs. One, because it is very difficult to learn how to use this software. I mean, clearly not super difficult because I did get like I got a D- in chemistry. I didn't fail, but I did not take like biochemistry or org chem, none of those things. But it does help me if I get results back that are disparate or not in concordance with what I found in the moment at my point of care, so that I can compare, bring that scan up and say, oh, this is how I missed this, or I missed that. It also gives us sort of surveillance, right? So like things that might be in smaller amounts that we could not detect on the FTIR, or maybe the FTIR libraries don't actually have yet. Nitazines is a really good example. So the first time we saw nitazines was not on the FTIR, it was confirmatory testing that came back. So it was in such small amounts that we did not see it on the FTIR, but now we are seeing it in amounts that we can detect on the FTIR, which means that they're above 4%. Does that make sense? That was
Yeah,
way
no,
really
no,
fast.
that was really fascinating. Thank you. Thank you.
And any other questions about this?
Not from me. Thank you.
Great. Okay, we'll keep moving. Cocaine samples. Again, this is a smaller subset of the drugs that we test in general, and we are actively working on that, particularly because there are pockets in our community. Like, let me be clear about this. Everyone uses cocaine, right? Does not matter if you are Black or white or Latinx, it does not matter. But in certain pockets of our communities, there are BIPOC communities where cocaine is the drug of choice, right? They may be using other substances, but primarily smoking cocaine. We as a needle exchange program don't have a lot of have not had contact with them and had nothing that they needed until we started giving out safer smoking supplies, right? So once we started giving out safer smoking supplies, that was an engagement tool that we could connect people to Narcan, right? Teach them how to do Narcan, teach them how to respond to an overdose, connect them to treatment, whatever they would need, and connect them to drug checking, right? So the safer smoking initiative is relatively new. It started in like 2018, 2019. It is, something that's part and parcel of almost all harm reduction services in the state now, thanks to the support of the Department of Public Health. It is still currently legally gray under the paraphernalia laws in Massachusetts. So, there's not without some controversy, but it is a really critical public health intervention to reach people that are dying of drug overdoses. We know that the rates of drug overdoses among Black and brown folks, Black and brown men in particular, have risen by 30% year over year in Boston. So like we need to do something different. But in cocaine, we're generally finding cocaine. So we're not really finding fentanyl. The 2 times that we found fentanyl, it is unclear whether or not that was some sort of cross-contamination or whether it was sold as something that was meant to be a mixture. So we don't know if this was a surprise or not to someone. So people do sell a mixture of cocaine and fentanyl. Those are what we call speedballs, right? With meth and fentanyl, it's called goofballs. Do with that information what you will. But we're not seeing a ton of fentanyl in our cocaine samples. We are seeing other things that are concerning. So levamisole is an animal dewormer. It can cause kidney failure, can cause agranulosis, white blood cell count dips. Phenacetin is a Tylenol-like substance that it was taken off the market years ago. It was never approved really for human use because it also causes harm to folks that are using it. So levamisole and phenacetin are 2 of the main cuts that are active found in cocaine that we're concerned about. All right, emerging trends. I'm getting to the end because I know that we have other speakers. So nitazines, right? In the past 6 to 8 months, we found 5 or 6 instances during drug checks. It has increased the number of the percentage that we're finding, right? I don't have concrete numbers for you because quantification is really hard with small amounts of drugs like this. But that is hopefully for future study, what MADS might start doing that. But we are seeing it on the FTIR. So I know that it is above 4%, which is, significant for someone that is maybe just used fentanyl and is coming across something that is maybe more potent than fentanyl. Not all nitazines are more potent than fentanyl. Some are less potent. There's about 6 or 7 different nitazines, from protonitazine, isotonitazine, metadnitazine. There's like 4 other that I can't really pronounce, but they all have different levels of potency. And so, it's hard for us to identify those specifically on the FTIR. Sometimes it's very clear. Protonitazine is one of the nitazines that we're seeing most frequently, which is slightly more potent than fentanyl. But we will discuss that with the folks that are coming in, talk to them about some of their risks. Again, like come up with a safety plan. How are you not going to overdose if you have both nitazines and fentanyl in your dope or in your heroin? Speaking of heroin, this is a shocker for me because since doing this in 2019, we have not seen heroin almost at all. In the last 9 months, it's been present in about 20% of our opioid samples, which is totally shocking to us. And in some ways it's welcome. I hate to say that to a bunch of folks that may be related to law enforcement, but let me explain what I mean. Heroin is much longer acting. You have to inject it less frequently. Fentanyl is, it's much less potent than fentanyl. So frankly, I'm okay with heroin maybe making a resurgence in the opioid supply. Again, xylazine prevalence is about 25 to 30% of our opioid samples, which has implications on, how people are responding to overdoses. So people may be able to restore breathing after giving Narcan is someone that has used something that's mixed with xylazine and fentanyl, but again, Narcan doesn't work on xylazine. Xylazine is sedating, so someone may be very sedated and hard to rouse or unrousable altogether, but their breathing may be restored. They just might require longer monitoring, right? Or, if you're going to send someone to the emergency department, that would be the person who's not, like laying on the sidewalk, maybe breathing, but not responsive. Medetomidine is something now that has recently popped up in the news. They have found it once in Worcester that I know of through the MADS data supply stream. In other places like Philadelphia, in Chicago, it's a little bit more prolific. It has been associated with several overdose deaths and overdose sort of, I guess what you would call spikes in those areas. I can only assume that we're going to see that as well in Boston, and synthetic benzodiazepines. We have only found that once in Boston, so hopefully that was a fluke. But again, Toronto sees it pretty extensively through their opioid supply, so we fully expect it to maybe pop up in the Boston supply as well. So these are all things that, as public health professionals, we're looking not looking forward to we're anticipating it in a good way. We're looking forward in a way that how do we adjust our overdose prevention programming? How do we adjust our our teaching of how to respond to an overdose? How do we start education early for folks with what we know and then adapt that as we move forward and learn more? It is something that we're just keeping an eye on. We already talked about nitazines. They've been around since the 1950s. Again, some of them are more potent than fentanyl. I want to kind of steer us away from the hysteria that sometimes happens when new things hit the market or hit the drug supply. I think understanding what's out there and understanding the very limited research that there is important, instead of sort of relying on this hysterical sort of like, oh God, there's nitazines in the supply. Like that helps no one, right? So we need actionable information that we can give folks who are directly affected by this, the people who use drugs, and the people around them, so that they can keep themselves and each other safe. They were never approved for medical use. They were first identified in 2019, so it is relatively new to the drug supply. Narcan will work on nitazines. They will work on nitazines. They are opioids, and there's no evidence anywhere that anyone could ever. I'm a part of a very large community of folks that are nerds and chemists and researchers, and we have asked time and again, is there actual evidence that there are naloxone-resistant novel synthetic opioids? And the answer is no. So always Narcan, always rescue breathing, always call 911. That's the messaging, and it can stay consistent over the years, and it should stay consistent. The effects that are what you might think, right? So increased risk of overdose, oversedation, more complex overdoses that require rescue breathing or oxygen for longer periods of time, increased tolerance to opioids for folks that use it habitually. So again, like as we see with xylazine, folks are not really getting treated adequately when they're in a hospital setting or in a detox setting for their withdrawal. So I'm hoping that the systems catch up with that so that they can retain people into these systems. But yeah, so that's just a little bit about nitazines, but I'm going to go, we've already talked about xylazine, medetomidine. I think that's good. So I want to just be mindful of the fact that, folks are waiting to speak, but I gotta stop sharing and I'm not sure how to do that.
Thank you, Sarah. That was excellent. Really informative.
Sure.
Do we, anyone have any questions? Just gonna, trying to scan the crowd. Just feel free to unmute yourself if you do have a question. Just gonna give it a second. No? Okay. Well, Sarah, thank you so much.
Thanks for having me.
I learned a lot, and we're really grateful for your time.
Thank you.
We're going to turn it over to Bill Murphy, who is the Director of Public Health in the City of Framingham. Bill, thank you so much for joining us. Director Murphy has been in his position since January of 2023 after a unanimous vote by the City Council. Director Murphy previously served as the Director of Public Health in Sudbury starting in 2014. Director Murphy has worked in public health after graduating college with a public health degree, and he's dedicated a significant portion of his career to serving the public. Director Murphy has joined us today to share with us information about initiatives taking place in Framingham. Director Murphy, thank you very much. I turn it over to you.
Thank you for having me. And thank you, Sarah. That was an amazing presentation. I couldn't write fast enough, and those words are long. So Thank you for the introduction. I have been the health director in Framingham for 18 months. I co-chair our local opioid task force, and we meet monthly. It was primarily set up to distribute these settlement funds. We have, in the past year, issued 3 significant grants to our stakeholder partners in the community, and they are dealing with the substance use issues and we're already established within the community. So I've also served in a number of suburban Middlesex towns, Sudbury, Wayland, Bedford, Burlington, Weston, and Reading. I've served in some capacities. I will admit this is my first attempt at a urban public health director job, and working for a city is much different than working for a town. Urban public health is complex, it's very diverse and very challenging. And I've learned so much over the past 18 months that I wish I had earlier in my career. But there's a heavy emphasis on health equity, social determinants of health, learning about health disparities and environmental justice. It's all extremely important in our practice as public health professionals. But applying it to practice is extremely challenging when you have a very diverse community like Framingham. So one of the things I first did is there is an amazing amount of data about your cities and towns that you can collect, and it's almost an immersion in that data. You can go to many different websites. Department of Public Health that we rely heavily on can give you a lot of information about your city and town. But our city right now speaks 73 different languages. It's one of our biggest challenges in providing any public health programming you do with the city. So I'll get into that a little bit more, but we now we translate almost everything in 3 different languages: Portuguese, Spanish, Hindi. We're now doing Haitian Creole, Ukrainian Russian is becoming almost 5%. So our ability to communicate with the community is extremely important to the leadership of the city, and we have to make sure that any program we run, we can effectively communicate all our programs in different languages. As opioid deaths decreased within the state of Massachusetts, unfortunately, it went up and increased in Framingham. And from learning from this data, it was one of the reasons we were starting our Narcan distribution program. One of the reasons we're launching it is we know one of our community partners, JRI, Project Rise, has distributed over 5,000 Narcan kits, and they're really working with our most at-risk community, our substance users, their families, and it's incredible to make relationships with these in partnerships with these organizations that already have these relationships developed. So it's extremely important as part of your entire community-wide programming is to recognize all those what those individual social service agencies are doing and support them as much as you can. But I think when you realize that our rates of opioid deaths are going up, or our numbers are increasing, that we may not be doing enough. So the reason for launching the program was really to get Narcan into the hands of everyday people, the parents, our grandparents, kids and friend groups, and it's still a way of also building a relationship with our community as a whole. I think one of the first things I think I would recommend anybody who wants to start a Narcan distribution program is make sure you get support from your leadership of your city. Communicate an action plan of how it fits into the overall programming of your department and your community, and also always back it up with data. Make sure you go in there and say the reasons why you're doing this programming and try to get community buy-in. I still think, like everywhere, we have a divided political situation right now, and everyone might not agree on the type of program that you're doing, but it's important to get buy-in. I also think, as Sarah mentioned, the value of harm reduction, and I still don't think enough people understand what harm reduction is and the importance of it. So I think as public health officials, we really have to do a much better job of communicating to our community why harm reduction plays an enormous role in treatment and prevention of substance use. One, and just keeping people healthy. It's a big public health component. We have to have comprehensive health program that really serves our entire community, even substance users. So extremely valuable. I want to thank the DA, though she was the first one to get naloxone into our hands, even before we could apply to the community naloxone program through the Department of Public Health. The DA had gotten our first shipment of Narcan that went very fast. So and we thank her for that. But we just want to make sure we have a steady supply. We applied to the community naloxone program through Department of Public Health. It's an extremely easy process. And their interest is really what we're going to do is getting Narcan out into as many people in the community and many bystanders as possible. For my department, I think you really need to assess your human resources, and that's challenging in my department. I have health inspectors that are out doing public health work, community health workers, a public health nursing program, but we wanted everybody in our department to have the ability to train someone in the community if they walked in off the street on how to use Narcan. And try it out, ask any questions they may have, talk about protection of themselves, signs and symptoms, but really give them sort of a real one-on-one as a way to build relationships with the entire community. We learned a lot in our department in the past 18 months. When I took this job, 20% of our children didn't have basic childhood vaccines. That was largely due to COVID and going to school hybrid and remotely. But we've had to, in a short period of time, vaccinate a lot of children. But we learn a lot about the families coming in, their limited access to health care, some of the disparities that exist, income disparities that will prevent them from getting health care. But we also are using this to as ways when we learn how we have to translate and people understand and communicate how that applies to our community naloxone program. That when people come in, we have to be prepared to train in multiple different languages, particularly Spanish and Portuguese, which is very prevalent within our community. It's also a way of sort of building trust. We want people to be able to walk in our door. We will expand our harm reduction programming, condom distribution, some fentanyl test strips, all those things that Boston is doing very successfully, but smaller cities don't have those resources to do it at this point. But we will be doing that. We want people to come to us first. Eventually, we will go out into the community. We're planning to have a mobile unit that will visit a lot of different community events where naloxone will be distributed at all those community events, and we'll have people out in the community. But this first step is every Tuesday. That's the day we work late. We work till 7 o'clock. We decided that we would open our doors from 3 to 6 and have advertised message to the community. For them to come into us, and they can be offered training. We have training in video training in multiple different languages, interpreters here to help people understand and have them leave with a kit of naloxone and feel comfortable on using it. I can't underestimate the value of messaging, and I think Framingham does that extremely well. We have a public information officer that is constantly messaging the community, but if the populations we want to reach, that some of those environmental justice communities we're able to reach through WhatsApp. More people are registering for WhatsApp, so we communicate in that way. But again, all our messaging goes out in multiple different languages, which is easily readable and understandable by the entire community. I think what also helps us, Framingham, is a lot. We're strategically located in downtown Framingham. We were given space, but that's where most of our overdoses happen. So it's a critical area for people to come in and get Narcan. We're easily accessible and centrally located. So again, our program starting on Tuesdays from 3 to 6. It will be expanded. It is an evolving program, like all our programming, but we consider it a valuable program to reduce opioid deaths in our community.
Thank you, Bill. That was great. I have a couple questions, and
Sure.
I was writing them down as you were talking, and then as you continued to talk, you answered some of them. So one of them was about the communication piece. So do you feel like the social media has been most successful in terms of letting folks in the city know what it is that you're offering in terms of Narcan and training and things like that?
Because this was just launched, we'll closely watch that. We did notice our first round of people that came in all mentioned getting it either by Facebook or some other other messaging that the city had done.
And you talked about the things that you found to be helpful as you started expanding resources in this area, including, the support from the community and the hierarchy, and also having data. So where did you find the data that you needed to, like bring these initiatives that you've established?
Yeah, I'll say public health is going through a transformation right now, and we're actually relying heavily on what we call shared services. It's a regional approach to public health that issues like substance abuse doesn't end at a town line or a city line. It is regional. So we have these regional groups with epidemiologists. So I think one of the values to me is to reach out to a regional epidemiologist. I get a much more objective look at data. So I think sometimes people might look that I'm skewing data to my advantage to run programming. To say that I can turn to an epidemiologist that can independently look at data, and I think the majority of the data we collected on substance use came from the Department of Public Health website. That you can get all of the substance use, substance incidents, and opioid deaths from Department of Public Health website.
That's great. Thank you. Do we have any other questions? I'm just gonna scan. But if you have a question and I don't see your hand, please just speak up. Okay, looks like no questions. Well, Bill, thank you. That was excellent again. I learned a tremendous amount. Do any partners want to share any updates? Thank you, everyone, for making the time. It's such a tricky time of year. So, hearing nothing, we will close out. Thank you, everyone, for joining us, and we will see you next month. And thank you very much to our speakers. Have a great rest of the summer. Bye-bye.